Okay, so thank you everybody for coming back for the second portion of our faculty talks, or the intro symposium, or however we're going to call it. I don't know. It's all very informal. I am once again Tom Wallach. Thank you for being here, and I am really happy to welcome two of my own colleagues who are going to be talking about both the innovative program we have here, and then the how do you handle your picky kid, and how do you get kids to eat new foods, which is a thing that is near and dear to my heart because my 5-year-old is impossible. So I'm happy to introduce first Dr. Shahzaib Khan, Dr. Shahzaib Khan, who's our second year GI fellow, also a professor, assistant professor of pediatrics at Aga Khan University in Karachi, Pakistan, who is going to eventually be setting up the first Peds GI educational division in Pakistan for us, and has been fronting our research effort around our feeding program. And then the linchpin of all of this is David Inzerillo, who is a dedicated speech language pathologist and a clinical lead here at Downstate Hospital with expertise in acute care, acute rehabilitation, subacute rehabilitation, and outpatient services for pediatric and adult patients. He excels in developing clinical initiatives, mentoring students and junior clinicians, and expanding clinical services in our community. He's established comprehensive policies and procedures, expanded speech pathology to the NICU and the PICU, and is leading our efforts to get us an outpatient SLP program, as well as improving our modified barium swallow program and pediatric inpatient feeding program, which he was a key to being able to set up because he's all of the domain expertise that we are relying on. So without him, this would not exist. And moreover, he's just really good at this. I have watched him do this with children, and if you can pick up 1/10 of what he does, you will be a much happier parent when you eventually have kids if you do not have them already. So I will welcome to the stage Dr. Khan. And are you his assistant professor? No, you're. And David.
Thank you, Dr. Wog, for that wonderful introduction. So we're going to do this in two parts. Wow.
Yep, recording. Great.
All right, so we're going to do this in two parts. I'm going to go first, and then we'll have David follow. So this is basically a talk about our feeding program, which we established about a year and a half ago at Downstate, and I think we've done great. So we'll talk a little bit about the program itself. We have no financial disclosures or conflicts of interest to report. And so when we talk about pediatric feeding disorders, they encompass a variety of conditions that interfere with a child's ability to consume a diet that's developmentally appropriate for age. Um, these disorders are mostly clustered in complex care patients and may lead to nutritional deficiency, social and behavioral delays, as well as poor physical growth. Feeding therapy is what facilitates the activities related to eating, swallowing, and mealtime tasks. And through behavior intervention and modifications, which David is going to talk to you guys about more, the therapist and family determine strategies to increase independent participation in mealtimes. So when we talk about the prevalence in the US, pediatric feeding disorders exist in about 1 in 23 to 1 in 37 kids less than 3 years old. And like we talked about earlier, these are clustered in children with comorbidities. So 1 in 3 children with comorbids have pediatric feeding disorders. And there's 4 areas that contribute to persistent feeding challenges. And these can be divided into medical, nutritional, feeding skills, and psychosocial. So our program, when we talk about that, we basically established that feeding therapy is a specialized treatment which is designed to assist children and their families in managing challenges related to eating habits and dietary intake. So traditionally, these children were more part of inpatient programs that were much longer, so anywhere from 1 month all the way to 4 months. And that was way too long for a lot of people, especially in our population. Unfortunately, these services were obviously they're intensive, involving multidisciplinary programs. They've been limited for patients in underserved populations, and so we established a 1 week program, sort of a comprehensive 1 week program, and that's what we're going to talk about in our talk today. So far, in our program at Downstate, we have had 14 children between the ages of 8 months to 9 years with a diagnosis of failure to thrive or avoid and restrictive food intake disorders. So these are the two kinds of patients that we took into our feeding therapy program. Each patient was evaluated by a pediatric gastroenterologist for potential pharmacologically treatable entities. So, for instance, constipation or EOE or reflux or food allergies. The admission was coordinated by the gastroenterology team, and the team basically consisted of four different entities. So we had the speech language pathologist, which is the most important. We had the pediatric gastroenterologist, the behavioral and developmental team, as well as the nutrition team. And what we used was so here's exactly what we did. So before the admission, we would send the something called a pediatric eating assessment tool, or the PEDI eat, to the family, and the family would complete this prior to admission. They would send it back to us, and we would share these with the entire team as well as the SLP. So what is the PEDI eat? So it's a wonderful tool. I got exposed to it in fellowship. It's a 78-item instrument, which is validated for use in children 6 months to 7 years of age with feeding difficulties when offered solid foods orally. It is intended to be completed by either a caregiver that is familiar with the child's typical eating, and then its scores are used to evaluate the caregiver's perception of changes in domains of physiological symptoms, problematic mealtime behaviors, selective restrictive eating, and oral processing. So each of these subscales then consists of certain number of items related to feeding difficulties, such as swallowing dysfunction, increased mealtime behavior, sensory processing, food selectivity. And David is going to talk about some of these things when he during his part. But essentially, we had the families fill out these questionnaires and then scored them. And based on those scores, we were able to identify whether this child had low concern for or no concern for feeding disorder, low concern or high concern in each of these domains, which were either physiological symptoms, problematic mealtime behaviors, selective restrictive eating, or oral processing. Each child would then undergo admission for 1 week of intensive inpatient feeding therapy, was assessed first by a pediatric gastroenterologist, and had baseline labs drawn. So CBC, CMP, iron studies, vitamin D, folic acid, and vitamin B. Each patient then had daily monitoring, so they would have daily weights, input and output monitoring, strict caloric monitoring, and we would document a food diary, and this would be done by the nursing staff. So the nursing staff would take pictures of the consistency, the timing of foods, the variety of foods, any associated coughing, choking, or gagging episodes with the speech language pathologist. And all of these photos would then be, we would talk about it in rounds. And so we wanted to assess our outcomes, and so we said, well, these sessions are conducted twice a day with the pediatric speech language pathologist. How do we assess our outcomes? So we said, okay, there's sensory and behavioral techniques which are employed, such as desensitization, feeding, allowing choices. So we can potentially assess outcomes as either increased acceptance to variety of foods, increased intake during mealtimes themselves, or caregiver carryover of feeding strategies after discharge. The patients were also monitored for changes in weight, caloric intake, and subjective reporting of caregiver of improved oral intake. And then the behavioral and development team comes in because so they would then be involved and be able to provide services to kids if these children qualified for services and they weren't already enlisted. So we'll take a 5 second Zen break because that's a lot of information. I don't have gifts, but I have this. So results. So a diagnosis of failure to thrive was associated with 9 patients, whilst a diagnosis of avoid and restrictive food intake was associated with 8 patients out of the total of 14. Out of 9 patients with failure to thrive, 8 demonstrated weight gain during the inpatient admission week with an average gain of 560 grams. So that's a big number out of the 9 kids. 13 out of 14 patients had acceptance to increase variety of foods, as well as successful carryover of feeding strategies to the caregiver. Within our cohort, at least 65 new foods were successfully introduced as well as tolerated, and 11 patients were plugged into outpatient feeding therapy program. On top of that, we had 5 patients who were plugged into services because of consults with neurology and then behavioral and developmental specialists. So Those are all great numbers. This is a table that represents everything that I just said. So as you can see on the left, you have our 14 patients, and then we have foods consumed on admission, which totals to 46, and then new foods consumed on discharge, which is about 60, as well as a bunch of new textures. So the total number of new foods that these kids or foods that these kids were taking on discharge was 106. On day 4 of the admission, we would have a multidisciplinary meeting with SLP, GI, or any other services that were involved, as well as the parents to discuss what progress we made. We would do a wrap up, which is basically review the pre-admission goals for the family and determine if progress was made towards these goals, and identify whether a specific issue was identified that needs more than just 5 days to work on. And then, of course, then we would transition these kids into outpatient oral feeding therapy. Determine factors which help make that progress, as well as any future potential challenges. And then for each patient, we would then do a feeding therapy patient experience survey, just because this is a quality improvement project. Would be administered at the end of the admission, and this is kind of our survey. So we would ask the family, what were your goals at the beginning of the feeding program? What do you think the 5-day inpatient program did help to achieve those goals? Do you believe that this program resulted in improved feeding? And then was there any techniques that we can improve in the program? And then we would establish care for outpatient feeding therapy. Currently, this is happening at NYU Brooklyn, but we hope to have our own outpatient program established soon. Followed with PEDS GI, and of course optimization of services. So if you have patients, this is an easy way to refer. I think the most important thing here is our emails. This is an older talk, so Miriam's email is missing here, but we can add that, who's a new first-year fellow. But the best way to reach out to us is through email if you have a patient. And then all of this information can be found in this QR code. So if you want to scan this, if you have patients that you want to refer over to us for our feeding therapy program, just scan this QR code. It has all the information on how to refer, what information we need, and we'll be happy to take patients. And with that, I'm going to give you guys another moment of Zen and then pass it over to David.
Okay, so I'm going to focus more on the actual feeding and swallowing from my point of view, but I will touch upon some of the slides and some of the information that was already presented from Dr. Khan. So I start with an actual full speech, language, and swallowing evaluation. It's not just swallowing. I also want to get a sense of how the kid is performing across domains, cognitively, with their play, receptive language, expressive language, so on and so forth. It's formal and informal. So I'm observing the patient, I'm talking to the parents, but I'm also doing some standardized checklists that I'm using for evaluations. For the evaluation, I use the Rossetti Infant Toddler Language Scale, again, if it's age appropriate. I use the Westby Symbolic Play Scale, again, because children's work is play, and that's a really good way to assess them. And I also use the Gard-Gilman-Gorman checklist of development. And the reason why I use these is they're quick. So I only have 5 days to work on a child who's had a feeding difficulty that's been growing over almost their entire lives, and I had 5 days to try to assess it and put them on the right path. I use them also because they're criterion reference. So I'm comparing typically a child with a developmental delay, not against their age appropriate peers, but against established developmental milestones. Why I'm doing this though is A, it's faster, like I said, but B, I'm not just trying to identify what they can't do. I'm trying to identify what the child can do, because the sessions typically consist of 2 sessions a day. One during a mealtime, which is a little more structured, and then I do one outside of mealtime where it's based around a play-based activity. So I want to get a sense of what the child's interested in, what they can do, and I'm using those to kind of help empower the child to kind of get their buy-in as well. Also, the Rossetti is good too because it can be parent reported, so I can interview the parents. I can observe it, or I can elicit the response, and I can just check it off that way. And I get a good sense, okay, if the child's at 6 to 9 months across domains, I'm going to create activities and play-based activities probably around that 9 to 12 months, a little bit further than what they're doing, and then trying to scaffold them to get there and showing the parents. I send the parents and actually providers and my students to the Feeding Flock. These 2 websites are really good. They're good for providers and good for families. They have a ton of information, a lot of research behind them. Joan Arviston is one of the gurus in my field for feeding. She has a lot of publications to her name, and she manages both these sites. So part of the evaluation, I'm king of questions. I have to ask 1,000 questions with the parents. So I'm constantly, that's why the Petty Eat is so good to get ahead of time, because breaks up domains. So I walk into the room expecting something. Okay, this child is likely going to have a physiologic dysphagia, or they have a behavioral issue, or a combination of both. So I kind of come into the room already expecting something, and then I kind of review it with the parents while I'm talking to them and assessing the child. But it's a lot of questions, and I tend to ask the same question throughout the week over and over, because sometimes parents are a little guarded with me in the beginning, but as I build rapport and get them on board, that they'll be a little more forthcoming in explaining what their issues are at home. And I review the intake. So is the issue sucking and chewing? Is it swallowing or choking? Is it GI discomfort? What are the weight trends over time? Is there food insecurity? Again, that's something you need to take into account. It's something that does occur, and we see it from time to time in some of our patients. So it's something you have to address. When did it begin? Are they receiving any other services, and how do they perform in school? So if they're in school, if they have an IEP, I'll ask the parents to bring it in. So we'll review that. Two reasons. One, if they're getting services, I want to see what they're doing already in school. Mom and dad took a week off of work. The child's taken out of school. So I'll try to bend my activities around the IEP as well. So there's some continuity. But also maybe there's some things they're not addressing. And then maybe we can get our behavioral teams in to either augment the IEP or get one in place for the child. So trying to hook them up into, a full range of services when they leave, not just swallowing. So I'm looking at current feeding. So it's more of like a quantitative intake part. I'm looking at the food groups. What are they eating? Are they not eating, or they can eat, or is it a physiologic issue? Is it behavioral? Are they only drinking milk? We get some children that come through. They're actually not failure to thrive. They're obese, but they're only drinking milk, or they're only eating one thing. It's a liquid and it's not age appropriate. If they're on GT feeds, what kind of formula is it? Is it nighttime feeds? Is it daytime feeds? Is it pump? Is it bolus? All those things are going to kind of affect me and how I navigate the child through the process. The other thing that's really important is going to come up throughout the talk is location and positioning. Location, I just mean like in the house. So mealtime routines are really important. Having that lunch routine or that dinner routine is incredibly important because it gives a child expectations. You expect these behaviors. It doesn't change. It's the same behaviors you expect every day. So you can kind of come together and then, okay, this is what's expected in this moment. And the children that are coming to us, a lot of times these daily rituals have broken down. If you're a working parent, just putting food on the table is incredibly difficult. Imagine now you're a working parent putting food on the table and then your child's not eating. So it's they get to the point where they kind of give up, or the child is not eating with them anymore, or they're eating in the living room, or they're watching TV, or they're grazing, they're not actually eating. So you really want to work on trying to establish those routines. So the location and positioning, the child needs to be sitting upright, needs to be able to sit, needs to come to the table, and again, understand what to expect. These are the behaviors that are expected. And then it takes some of that negative reinforcement off the table, because that's it. You want to create a sense that this is a good feeling, not that they're habituating these bad habits because the child doesn't feel good. And again, so negative reinforcement is, you really want to try to nip that in the bud. So I want to know what a typical day like is for the child at home, but also in our clinic. I want to know what their daily intake is like. Are they eating full meals, or are they grazing all day long? What portion size they're using, what volume size, what's offered, what's consumed. How long does it take to complete the meal? A child that's taking a long time to complete a meal might actually have an underlying physiologic dysphagia, not a behavioral issue. What's consumed? Is it consistent versus inconsistent? They eat well for lunch, but they won't eat dinner, so on and so forth. Were they eating foods that they're no longer eating? That's also important to note. Maybe how did this start? And what the mealtime routines are. So, and then I've kind of worked through my evaluation on the first day. I've done my oral mech exam, my cranial nerve exam. I've talked to the parents. I've interviewed them. Now I'm going to watch the child actually eat what the parents feeding them. So we'll use their preferred food. I'm not trying to stop them from eating their food. The kids need to eat. So when they're in with us, we don't want them losing weight. So whatever they're eating at home, we have them bring it in, and they're going to eat that as well. We're just trying to then build upon that to set them up for success when they leave. So from the mealtime observation, from a cranial nerve point, I'm looking at secretion management. So are they able to manage their saliva? Is the food falling out of their mouth? Do they have good buccal tension? Is the tongue lateralizing to both sides? Are they forming a nice bolus? Is there good AP transport? When they swallow, is it all over their mouth and all over their tongue and the buccal sulcus, so on and so forth? So you're kind of looking at all those things to get in a sense that this child may have an actual physiologic issue that's exacerbated by all these behaviors that then kind of glom onto that. And then you have this self-fulfilling prophecy. So the child with the GI discomfort, same thing. If there's pain or there's dysphagia, you might address that underlying pain, They might go see Dr. Wall or Dr. Khan and they'll address the discomfort in the GI area, but all those behaviors have been so habituated that even though you've taken away that organic cause, they still have these behaviors. So it's trying to work through that and figure out where they are. And again, a lot of this is you have to meet the child where they are, and then you kind of scaffold them out and pull them kind of out of it. So once I do all that, then it's the kind of a jumping off point for the actual therapy part. So this is just I'm a visual person, so I kind of just mapped out this is the interdisciplinary team that we do for the feeding program, and I kind of just worked out the actual dichotomy that I follow based on the evidence for the actual feeding therapy. So I'll select interventions based on this after my evaluation. It's typically either oral motor, behavioral, or sensory processing. The behavioral I break down into operant conditioning and exposure therapy. And again, I work them through that. And while I'm doing this, I'm also talking to the parents so they get to see and understand like what we're doing. So I'm working with both of them at the same time. I'm working with the child, but I'm also narrating everything I'm doing to mom or dad so they can kind of pick up on this too. And again, it's incremental changes over the week that set them up for success down the road. The behavioral component too is I'm not going to remediate behaviors in 1 week. All I'm going to do though is get a small window open for the parent and strategies to give the parent to then get carryover at home when they actually go home and go and set them up for future success. So the oral motor, these are strategies that are manual interventions. So it's direct guidance, stretches, oral desensitization to manage various textures and consistencies. Again, this feeding program is based on the evidence out there. So the evidence shows that working across those 3 domains really gives you good results in working with children with feeding difficulties. Behavioral techniques. So these are looking to yield positive outcomes in increasing oral intake with children who have feeding difficulties. And then there's sensory processing. So sensory processing and behavioral techniques kind of sometimes the line is blurred. But here I'm not addressing the behavior. I'm addressing the underlying issue that's causing them to have this behavior. And we'll talk a little more about that as it goes on. But again, to try to get rid of that sensory defensiveness or that oral defensiveness. So the oral motor component, the component, the dysphagia component, again, I'm looking at lingual range and strength and range of motion, buccal support, lip rounding, labial closure. If there's any issues there, then in my sessions, I'll use it more like fun. We'll develop games to try to elicit those movements with the tongue and then teach the parents how to do that. The behavioral, again, it's operant conditioning. This is just unconditional positive regard. It's just lots of high fives, lots of cheering. You have to be like really into it. I leave the room after these sessions, I'm like emotionally, physically spent because I have to you have to really work with this child. You're really trying to, it's a child that's already difficult to reach because of whatever developmental delays they might have. So you have to really work really hard to kind of get them in and make them feel like they're having fun. That's the whole point. It has to be fun for the child. Otherwise, they're going to run away from me. So again, errorless learning, which is just I give them the answer or what the target behavior that I want, and then we have them do it. So they give it to them, and then you show them, and then you have them do it. You show them, have them do it. Immediate reinforcement, that's my high fives, that's my cheering, that's my jumping up and down. Escape extinction. And trying some children, it's difficult to get them to even just to come to the table. As soon as they know what we're going to do, they run out the room. So again, trying to work on, okay, you can run out of the room, but we have to do these couple of things first. And at least you get that small, okay, open-mindedness. You're just looking for a little bit of an open mind. And then shaping. A lot of what I'm doing is shaping. So the child might allow a piece of apple to touch their teeth. That's great. But then we want to now shape that into actually biting the apple or actually chewing it. And again, we kind of use the sensory desensitization, which I can't say, to work on that if the child is having some oral defensiveness. For the exposure therapy part, you're just trying to reduce the avoidant restrictive behaviors. And it's a bit of a misnomer. So we use demand fading, texture fading, portion fading. I allow choices and I allow to have preferred foods. The fading isn't getting rid of it. The fading is increasing it. So that's why it's a bit of a misnomer. So my demand fading, I only might want you to try a little bit in the beginning, but as we work through this, I'm going to actually increase the demand to take more. Same thing with a portion. We'll start maybe just with a small amount in your mouth, but then hopefully by the end of the week, how did that whole teaspoon get in there? I don't know, but now you have a whole teaspoon in your mouth. And again, allowing choices. You have to have the child and the parent feel empowered. You're trying to get this child to feel like they're kind of running the show, even though you're working them through a whole maze that you've created around them, but they have to feel empowered. If the child's empowered and feels like they can make choices, I get better results anecdotally, actually. And I'll even throw in like a couple of food items that I know they're gonna absolutely hate, because then I can say, okay, we can get rid of that. And they're like, oh, this guy's reasonable. Okay. Like blackberries. Nobody likes blackberries. I get in the kitchen. They're bumpy, they're hairy, they're black. None of the kids like them. I love them. I thought it would be a great thing to use. But I'll bring those in there and write every kid so far be like, no. And I'm like, okay, look, you're the boss, no problem. But let's try this carrot now. And they're like, okay. And they'll give me a little bit. And then we kind of build upon that. But again, having fun with it. The one time is through the mealtime where we set the mealtime routine. We're going to sit, we're going to eat. I might even eat with them. Mom will eat. And then this is what we expect. And we'll layer in some language and some other stuff. But when I see them again later on in the day, it's through some sort of craft activity that I'm funneling them through. So they're having fun. And then we're sorting the food into cups and they're taking it out and they're trying it and they're putting it back. And how's the mouth feel? Is it good? How does that mouth feel? I give them like a couple of questions and I let them kind of, okay, we're going to put that in the maybe pile, the no pile, and these are our yeses. And if you keep giving that to them, they typically do kind of give you something. Even for the most difficult children to work with, they will give you something. Strategies for sensory processing. So again, this is not the behavior. This is trying to get to the underlying, whatever sensory aversion you're having, you're trying to address it. So a lot of this is positioning. So a lot of these children, they have also low tone. They don't have good trunk support. They're not sitting up properly. So to eat regular foods at a table, you need to be able to sitting upright, legs underneath you, hands in front of you. So we'll try to support them. We have high chairs. We'll get some pillows if we need to. I have a bumbo, which you saw the other day, Dr. Wallach. I'll actually bring that in the room just to try to get the child positioned properly so we can feed them, especially if it's a child who's only drinking out of a bottle. You know, mom's holding like a football. Now you're going to eat not like that anymore. Now you're going to eat in a completely different way. But it's important. And then the proprioceptive and vestibular input. We had a child come through who was an infant who every time I fed him the bottle, about a minute in, his nostrils were flaring, his back was arching, he was pushing away from me, almost to the point where I suspected he might have a dysphagia. One day I kind of just stopped with him and I just started playing the up game. Up, 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 up. He was laughing hysterical. He loved it. I felt his body relax, kind of nuzzled me in my neck here, which was super cute. And then once he did that, I kind of slipped him down and then he just took the bottles. And it was, once I gave him that vestibular input, he needed that to organize himself, for his system to feel comfortable. And he was pretty easy to work with at that point. So it's important. The positioning and that vestibular input are really important for some children. So what's important also, I'm going to talk a little more about the signs and symptoms of dysphagia. So pain and dysphagia often aren't obvious in our children with developmental disabilities. They oftentimes have had surgeries at birth, they've had fistula repairs, they have dysmotility of the esophagus, they have all these issues that are kind of combining together. And then what happens is you have a dysphagia or you have pain associated with eating, then you start developing these maladaptive behaviors around it. And like I said before, it becomes a self-fulfilling prophecy. The longer it goes on, the more these behaviors come, the more they're habituated, the less the kid is eating, the more restrictive their food intake becomes. So again, signs and symptoms of dysphagia, obviously the obvious ones are coughing and choking, wet vocal quality. So after they swallow, you hear their voice, they sound like they're underwater. I cervically auscultate, so not to detect aspiration, but just to build a risk profile of the child. I do it in serial assessments throughout the week, but I'm listening for throats for wet breath sounds. So no change in breath sounds is actually clinically not useful. It means nothing. It just means I didn't hear it. But if I hear a change in the breath sounds, that might be a sign that this kid is having some sort of dysphagia. There might be a physiologic organic cause. And then we're going to do a modified barium swallow in that child. Reduce hyolaryngeal excursion. Of course, that's poor airway closure. Increased respiratory support. So as they're eating, their O2 sats either might be dropping or the respiratory rate is increasing. The kid is really working hard to swallow. Maybe it's because they're trying to catch up and they can't manage the food. And then some children have a history of pneumonia, croup, bronchitis. There's no real cause for it. That child also might have a difficulty, so it might be related to swallowing difficulties. So when I do my assessment and I do see those symptoms manifest, then we're referring the child while they're here for a modified barium swallow, which could be inpatient or outpatient. These are two videos of two young children I did. On the left you can see delayed esophageal emptying. It's kind of hard to see here. There's a bit of contrast in the distal esophagus before the there. That is really the whole issue. We think in the rice formula, the child was actually able to tolerate the bottles. To the right of that is a school-aged kid, a preschool-aged kid who had a cleft palate repair, and that's actually a normal swallow. So you see a nice contrast in material going towards the upper esophageal sphincter and into the esophagus. You don't see any open air pockets. Everything is closed tight and looks great. That's a great swallow. This is another child we saw here. at downstate, ready to modify. This is after a tracheoesophageal fistula repair. And you can see this child actually needs another dilation. So in the mid to proximal esophagus, you have the distension because there's so much food going in and it can't go through that small area. So that's what you see there. So that child actually had another dilation. We did another modified and he was good to go. So the take home message, you have to recognize dysphagia. Again, it might not be so obvious, but if there is a physiologic component involved, not just a behavioral component, they're going to go hand in hand. And it's going to be very difficult to address those behaviors if that dysphagia is still persisting. So again, choking, coughing, gagging, taking a long time to eat, and is mealtime fun? If the child is miserable every time they're eating, they might be trying to tell you something. They just don't have the words to use it. And again, for take-home message, recognize pain. So pain and dysphagia kind of go hand in hand. Your food aversions or your difficulties can be caused by an underlying pain or an underlying dysphagia. Common sources of pain typically are constipation. A lot of our children, especially from GI, are coming, they're constipated. If they have reflux or acid reflux, cow milk protein allergies, so on and so forth. So again, for referral for evaluation for GI, older kids, when they consider endoscopy, food is getting stuck, drinking extra liquids at meals, eating slowly, they're cutting food into very small parts because larger bites are causing them discomfort. And for swallowing, again, problems mentioned above, persist or severe, there's weight loss, eating restrictions that cause deficiencies, failure to thrive, obesity, special needs children eating slowly, not gaining weight or not growing. Those are all children that would be appropriate to maybe refer for a modified barium swallow. To schedule 1, 2, these are the 2 contacts we have here. And up at the back of the room, I have some flyers and marketing material for both pediatric and adult modified barium swallows. That's it. Thank you.
Thank you guys so much for that great talk. Are there any questions? If there are not, we can move on to our next speaker. All right.
Thank you.
Thanks, guys. Okay. It's open already? Okay, great.